Hi, Dr. Pahl.
Hello,
Welcome.
hello.
Thank you for being here. It's my pleasure to introduce Dr. Pahl. Dr. Pahl is a nephrology specialist at the University of California, Irvine in Orange, California. She is the principal investigator at UC Irvine in the NDDK-funded national study, the Family Investigation of Nephropathy and Diabetes, which is a multi-center study designed to identify genetic determinants of diabetic nephropathy in different ethnic groups, using a variety of strategies to localize susceptibility genes. Once again, thank you for being here, Dr. Pahl, and I will turn things over to you.
And I'm charged to talk a little bit about the methodologies that nephrologists employ in preserving kidney function. And as I'm sure all of you know, chronic kidney disease is becoming very prevalent in our world. And there's a global prevalence of approximately 10%. And irrespective of the cause of kidney disease, it can be a progressive disorder and ultimately can result in kidney failure. A significant percentage of the world's population has developed kidney failure, what we used to call end-stage renal disease. Many of you recognize that acronym. Now it's end-stage kidney disease. And the important purpose of this lecture is to demonstrate that the CKD progression, chronic kidney disease progression, can be minimal or can be severe. It can vary on multiple factors. And while we cannot reverse chronic kidney disease, we can stabilize. And that's what I would like to present these upcoming 20-30 minutes on the things that can be done to achieve those results. Okay. I put this slide with our UCI anteater to remind us about UC Irvine's contribution to the management of chronic kidney disease. And I'm going to talk to you about the prevention, as you see in green there. But there are other factors that need to be considered. You want to make sure that or your doctor should certainly make sure if you have a diagnosis of chronic kidney disease, that you are being treated for any potential reversible cause. And then, of course, we're going to discuss the prevention of its progression or slowing it down. And then, as part of any chronic kidney disease lecture, but not today, most patients and nephrologists are also dealing with the complications of kidney disease and the treatment of those. Everyone knows about anemia and the treatment with a variety of agents. And then, as a nephrologist, I can't give up the chance to remind everyone who has progressive chronic kidney disease in late stages that it is very important to prepare for some form of renal replacement therapy, hemodialysis, peritoneal dialysis, or ideally kidney transplant. But I want to just highlight some of the factors that are associated with chronic kidney disease progression. Obviously, to everyone, the cause of chronic kidney disease, if left untreated or unmanaged, is likely going to make things worse. So treating the underlying disease, as I'm sure all of you are thinking, for example, diabetes, one of the most common, if the most common cause of kidney disease in this country. If the diabetes is not treated, then the progression is exacerbated. Additionally, the treatment of other comorbid conditions associated with the kidney disease can result in worse progression. For example, diabetes, high blood pressure, and heart failure. So if you have heart failure associated with these disorders, and the heart failure is exacerbating or untreated, it can result in worse kidney function. The same for liver failure. Okay. Important to address reversible causes. I'm not going to spend a lot of time on lifestyle factors. I'm sure everyone on these conference has heard the slew of recommendations for reduction in all of these lifestyle factors, including diet and smoking, ideally stopping smoking. And then I'm going to talk to you about the implementation of treatment modalities, particularly the new treatment options that have become available in the last few years. I put genetics there because genetics can play a role in your kidney disease diagnosis, as any of you who have autosomal dominant polycystic kidney disease can attest to. But additionally, some genetic abnormalities may actually exacerbate the progression. And there's a lot of work ongoing on trying to identify these factors and hopefully generate novel therapies that can be individualized and result in improvement of the progression of chronic kidney disease. Okay, so I have to put a slide on the management of underlying disorder. I already told you, and I'm sure you could tell me, the most common cause of chronic kidney disease in this country, diabetes and hypertension. If you have poorly controlled diabetes, you likely will increase your chance of getting diabetic kidney disease. And if you continue to have poorly controlled diabetes, you will increase the rate by which the chronic kidney disease progresses. So that if you were going to have chronic kidney disease without needing dialysis or transplantation for 10 years, you now are going to have it for 7 or 6 years. So it's worth the effort, even, I mean, of course, for everything else, all the other complications of diabetes, but even for the management of chronic kidney disease to control the blood sugar. And there's a variety of targets that have been proposed. For most patients, the recommended target is a hemoglobin or glycosylated hemoglobin less than 7%. Get that with diet, with medications, with insulin, and you are doing the best you can to reduce the progression based on the issue of diabetes. Hypertension, we're going to talk more about this in terms of blood pressure control and the role on progression of chronic kidney disease. If your disease is essential hypertension and it has caused kidney damage, it's important to treat the blood pressure. As many of you know, hypertension is a common complication of chronic kidney disease, irrespective of the cause. If you had a glomerular lesion, if you have lupus, if you have any other, if you had a urinary tract obstruction that caused kidney failure, over 90% of patients develop hypertension. In that population, it is also important to control the blood pressure to prevent progression. Other underlying disorders you see there, there's a slew of them. Obviously, we're not going to address all of them. I'll be here all day, but you understand that many of these disorders may have specific treatments that address the disease directly and reduce the progression. The autosomal dominant polycystic kidney disease is now being treated in certain cases with medication. The treatment of lupus, autoimmune diseases can reduce the kidney injury and prevent progression, et cetera, et cetera. I always like to put the environmental exposures and geography location because now we're seeing more patients coming from Central America with the Mesoamerican nephropathy that may be related to exposures that are ideally can be removed if they're no longer in the agricultural centers. Okay, but also before I start talking about the medical treatments for prevention of progression, you should always think of possible reversible causes that can be addressed. Episodes of these that can cause acute exacerbation of kidney disease, even when they recover, can add to the risk factors of rapid progression. So it's important to be alert to these things, to make sure you don't get dehydrated. That causes reduced blood flow or perfusion to the kidneys. Obviously, everyone's telling you to drink fluid. You need to adjust that individually based on your level of chronic kidney disease and how much urine you make. But prevention of hypovolemia or dehydration is important. Prevention of very low blood pressure. If blood pressure medication isn't managed correctly and it results in very low blood pressure, this could be a problem. Attention to infection or severe infections and sepsis. Prevention of urinary tract obstruction. And we see this not infrequently in older men as they perhaps begin to get a component of prostatic hypertrophy. And this could add to the worsening of the chronic kidney disease and should be at least evaluated. And finally, in a variety of settings, the administration of agents that can hurt your kidney or nephrotoxic drugs, and the classic one over the counter being the non-steroidal anti-inflammatories such as Advil, ibuprofen, Aleve, these agents that ideally should be avoided in patients with chronic kidney disease. I have only one slide on diet. There are many more experts on diet, but I bring it up because the idea, and particularly in people who want to lose weight, that they should, and if indeed obesity is an aggravating factor or even a cause of their chronic kidney disease, the idea that high protein, low carb diets might be beneficial is questionable, particularly in people who have chronic kidney disease in the stages 3 to 4, where high protein diets can exacerbate the progression of chronic kidney disease. And when we're talking about protein restriction, we're talking about levels of less than 0.8 grams per kilogram per day. Some of you may be familiar with what were intense protein restricted diets that were used or still occasionally used as treatment to prevent progression of chronic kidney disease. And these included diets that were as low as 0.6, 0.5 grams of protein per kilogram of body weight. And those require very close nutritional follow-up. They may require people to get special supplements of some essential amino acids. But the point here I wanted to make is about no high protein diets. And there's a lot of information suggesting less meat protein sources and more plant sources might be beneficial. And here is a scientific evaluation of the reduced protein intake and its effect on the progression of chronic kidney disease. And this has been a moderately controversial topic, particularly since older studies done, that was the what was called the MDRD study, that failed to show significant effect of low protein diet. And that's its methodology and evaluation has been criticized. But here I thought I would show you a review of many studies, what's called sometimes a meta-analysis, that suggests that if you have certain disorders like diabetes, certain glomerulonephritis, if you reduce protein intake from 0.6 to 0.8 grams per kilogram of body weight per day, you can see that the progression of kidney disease, how your kidney function drops over time, is less steep than if you're following a normal diet. So we and many others recommend protein diets of about 0.7 grams of protein per kilogram of body weight to all our patients that have chronic kidney disease stages 3 and above. Okay, I promised I'd tell you a little bit about blood pressure and how to treat it. And There have been slew of studies and discussions about this topic. And the real question is, how low should you treat the blood pressure? Should you treat it aggressively in a 20-year-old, less aggressively in an 80-year-old? All of those issues may indeed be important, but I'm going to only highlight to you the data obtained from a study that's been published now for 7 years called the SPRINT study. I'm sure all of you have heard about it. And it compared the effect of intense blood pressure control with less intense blood pressure control for patients that didn't have diabetes, but some had kidney disease. What did this study that's been quoted extensively demonstrate? It showed that in individuals in whom you controlled the blood pressure below 130/80, and these it closer to 120 to 70, there was a substantial reduction in cardiovascular diseases, particularly strokes. But it did not seem to do much for reducing the progression of kidney disease. GFR reduction seemed to be the same. And interestingly, in a certain subset of patients, those who had chronic kidney disease, some actually with intensive therapy had a little bit of worsening of their kidney function. Their creatinines went up a little bit and the eGFR was worse. Okay? The interesting finding is that in other patients who have a lot of urinary protein, you can show, and here is a meta-analysis, a combination of a slew of trials that included almost 45,000 patients, that intensive blood pressure definitely reduced those cardiovascular events and also stroke. Also reduce urinary protein, which can be used as a surrogate of improving kidney disease. However, there was no clear effect on the progression of the chronic kidney disease or the onset of end-stage. Here listed ESRD, it was in the 2016, or end-stage kidney disease. So what do? We try to treat patients who have hypertension and chronic kidney disease, definitely to below 130/80. You want to make sure that they do not develop symptoms of dizziness or dropping blood pressure when they stand. And we carefully adjust those medications to attempt to achieve levels of approximately 120s systolic, understanding that we're treating the whole person. We're reducing strokes, we're reducing heart attacks, and we want to make sure that we do not in any way cause worsening kidney function, okay? So this is the way the nephrologist approach. A cardiologist approach might be a bit more aggressive, trying to ensure they're preventing cardiovascular disorders, but we always say, watch the kidney function as this is done. Now, for the specific treatments associated with improved slope or progression of chronic kidney disease, I am sure everyone in this audience has heard about these agents, whether you recognize them as being called renin-angiotensin system inhibitors or not. We're going to call them RAS inhibitors. And these are the medicines that are the subsets are called ACE inhibitors, angiotensin receptor blockers. The original ACE inhibitor, captopril, there's enalapril, lisinopril, the angiotensin receptor blockers, losartan, valsartan, all the TANs and all the prils. These agents are, in our mind, the cornerstone of management of chronic kidney disease. They have been shown to reduce the progression of chronic kidney disease initially in type 1 diabetes, the captopril studies that showed a significant reduction in the GFR slope that would be getting worse and worse. It subsequently was shown in type 2 diabetics. It's subsequently been shown in non-diabetic chronic kidney disease with the ACE inhibitors and the angiotensin receptor blockers. And here is one of those old, very commonly cited studies called the Rhine study, okay, like people would pronounce them. And what you would see here, this were patients who were given ramipril. And if the guys that were treated with the ramipril, the slope of worsening of GFR decline, okay, was flat. If that were your money, you'd be mad. But if that's your kidney function and you didn't have the ramipril, the slope of the GFR was decline was steep. That meant this GFR was higher than this. This is a GFR decline. It makes you confused. But this is the good one in this study. It also demonstrated another combined endpoint, which was another endpoint of the study was how much protein was being excreted by the kidney. High protein excretion is associated with rapid progression. And I'm going to talk a little bit more about that. And the use of these agents resulted in a reduction and a stabilization of urinary protein excretion. So we try to give everyone one of these agents. The problem comes with the side effects. The common side effect of the prils, the ACE inhibitors, is a cough. Some people start to cough. It's a dry cough. It's annoying. We can remove the agent and traditionally successfully convert to an R, and the cough goes away. That's, to us, a minor issue. The more concerning problems with the ACE inhibitors and the angiotensin receptor blockers is dropping of blood pressure. We try to give these agents even in people who have protein in their urine and their blood pressure is normal. Case in point, a diabetic, type 1 diabetic with some proteinuria, albuminuria, and their blood pressure is 125. We give low doses to try to reduce the protein and preserve the kidney, but we have to make sure we don't drop their blood pressure. The second issue that's very common is high potassium. And many of you that have been treated with these usually have high blood pressure, hypertension. And so the low blood pressure is not an issue. It's a wonderful effect. But the potassium can increase as a result, a direct effect of these agents. And people have to watch their diet for potassium intake. And recently, with the use of some of the compounds that can help excrete potassium, for example, patiromer, and they help excrete potassium in the gut. In people who are having good response to these agents, we will keep it, even though it's caused high potassium, and add an agent to control that complication. Sometimes that's a hard sell for patients, which is why I'm spending time on here. They'll go, really? You gave me a medicine, it gave me a side effect, now you want to give me another one? But the reason we're doing that is not just because you can't use another medicine to control the blood pressure, but because of this added benefit of these agents in preventing the progression. The last concern with these is that in some patients, particularly those that have arterial blockage, renal artery stenosis to the kidney, they may cause an elevation in creatinine. And so we traditionally start the agent and carefully check not just potassium, but the serum creatinine, measure kidney function after the initiation. And we'll tolerate a little bit increase And by the way, that doesn't mean your kidney is going to get worse. In fact, in those patients, even with a slight increase that is maintained at that level, you still see the protection in the progression of kidney disease. What we don't want is continued increase or a severe increase in the creatinine. In that case, those agents will be stopped. Okay, this is the new kids on the block. And the reason I think this lecture is important in today's environment. And those are the new agents that have been developed for the treatment of diabetes. Those are the sodium glucose cotransporter inhibitors, SGLT2 inhibitors. They have commercials on TV, all sorts of things for these agents. You may have seen their name, empagliflozin, dapagliflozin, canagliflozin. Jardiance is one of the trade names. These agents were initially developed, as I said, for the treatment of diabetes. They make you urinate glucose. When they were first given, they were wonderfully shown to also be associated with lower blood pressure. They improved the blood pressure. Then it was noted that in those people who had urinary protein, that the protein dropped. And then at the end of the trials, it was documented that the progression of chronic kidney disease was reduced by even 40% with these agents in diabetic. That led these companies to pursue studies, which as I've shown you here, in non-diabetic kidney disease. These agents have now been shown here in this one study presented just last year in patients who had glomerular disease, no diabetes, that when they were added to, look, the cornerstone of ACE inhibitors or angiotensin receptor blocker therapy, these agents significantly reduced the risk of chronic kidney disease progression. Look at this graph, even I can tell the difference. There's the placebo, and here was the addition of this agent, dapagliflozin. In some patients, by the way, when you give this agent, the creatinine or kidney function, it initially gets a little worse. So the creatinine goes up, but the progression of chronic kidney disease is significantly lower. And you'll see that if you look carefully here, that it goes up, but then it stabilizes. We use these agents in at least in patients with CKD3, and sometimes as you see GFR as low as 28 or 25, and we follow them carefully. Another benefit of these has been that it actually can reduce potassium, particularly if there was a problem with hyperkalemia with ACE and ARBs. Nothing is free though. And the side effect of these agents, you can well imagine, the amount of sugar or glucose in the urine is infection, bladder infections, and infections in the perineum, genital infections. So we have to be very careful in patients who have a risk for this. In some cases, and if you look at the package inserts of some of these agents, they actually have said they are contraindicated in patients with immunosuppression. For example, the kidney transplants. There's been a few studies in kidney transplant patients in whom these agents were started, and there was no real increase in the incidence of urinary tract infections or genital mycoses infections. We've done it in our transplant program. I have over a dozen people that I've treated with for the most a year and a half. We carefully choose who to provide this if we think they would benefit by making sure they don't have ongoing asymptomatic bacteria in their urine. We won't give it. Of course, if they've had a history of urinary tract infections, we won't give it. But in patients who have a lot of protein excretion, who have poor diabetic control, we've added these agents. We have not done it in non-diabetic kidney transplant patients. So we've reserved it for the diabetic patients. But I can alert you that a lot of work is being done in these agents, and you may see them coming up. If your doctor wants to add these medications, if you're a diabetic, or even a non-diabetic, and you wonder when you look them up, what? This is for diabetic patients. I show you this information so that you can realize what a significant impact, a positive impact it's had on the management of chronic kidney disease. The second ones have been the role of what are called mineralocorticoid receptor antagonists. Now, these are agents that block aldosterone, okay? And these have been shown to reduce the progression in diabetic kidney disease. They have not been shown to do so in non-diabetic kidney disease, although we know that these agents can also reduce urinary protein in non-diabetic kidney disease, where agents such as spironolactone have been used. This newer one, finerenone, these are the cousins of those agents. Their problem has been high potassium, hyperkalemia. And you can imagine in those who already had a problem with high potassium on one of the ACE or ARB agents that we talked about, this could be a difficult thing to start. But I show you because this studies have just come out and published in the last year or so and have shown a very positive outcome in diabetic kidney disease. So many patients will likely be offered this therapy. And again, close observation for particularly the concern for high potassium needs to be maintained. Also in diabetics, but not shown in non-diabetics, is the role of these agents, glucagon-like peptide receptor agonists. Now, these are the shots, you may recognize them, semaglutide, dulaglutide, exenatide. These are approved for the treatment of diabetes. It's a gut hormone that makes your pancreas secrete insulin. It's also been approved for weight loss. You don't have to have diabetes. You can get one of these agents, and they have successfully shown to reduce weight. They too have been shown in type 2 diabetics to reduce protein or albumin in the urine and slow the progression of kidney disease. Because these preliminary studies showed such good outcomes, still in diabetes, there is now a large trial ongoing with semaglutide, and the outcome is in kidney disease progression. And hopefully in the next year or so, we will get to see some of these results. Ideally, these agents, if they show to improve in type 2 diabetes, may have a role as the SGLT2 inhibitors showed in non-diabetic kidney disease, and could possibly be an agent that could be used for obesity management and kidney protection. Now, less exciting and just kind of boring, but I put here, I think I have a few more minutes, is the treatment of acidosis. And I put it because many patients are prescribed bicarbonate, and it's tedious to take this pill 3 times a day, twice a day, but it's been shown to cause protection in the progression of chronic kidney disease when you control the bicarbonate above even 24. So I quickly show you that. And I tell you here that in 134 patients, this old study now demonstrated reduction in chronic kidney disease. But you have to be careful, even though it's not sodium chloride, sodium bicarbonate, we have to watch for blood pressure and fluid. And this can be managed easily by simply attending to it, okay? I tell you again, because You can get alkali therapy, basically bicarbonate therapy, by eating less protein and more vegetables. It will result in pretty much the same increase in bicarbonate in your blood. So in summary, these are the things that you can consider to try to prevent the progression of chronic kidney disease. And I wanted to highlight the new agents, which were the SGLT2 inhibitors and the non-mineral corticoid receptor agonists. And blood pressure control, and of course, as always, primary care, attention to the primary disease and diet. Is there any questions? I think I'm on time. Let me know. I can't see my clock, but.
Thank you, Dr. Pahl. Yeah, that
yeah.
was great. We do have a few questions. Let's see. First, what's behind the increase in CKD? If kidney disease is caused by inflammation, can reducing and eliminating inflammation reverse the condition?
Yeah, well, the increase in chronic kidney disease is thought currently to be related because of the increase, at least in this country, increase in diabetes, increase in obesity. And yes, inflammation can exacerbate the progression of chronic kidney disease. And these agents, many of them, have a common pathway of reducing inflammation. So when you reduce blood pressure, you ultimately also reduce inflammation. When you control blood sugar, you reduce inflammation. When you give these SGLT2 inhibitors, part of the effect in the kidney is thought to be reducing not just glucose and the hyperfiltration of the kidney, but when you do reduce this hyperfiltration of solutes through the kidney, you reduce inflammation in the glomerulus. So yes, the answer is yes, but not with what people think is a routine anti-inflammatory. No Advil. No.
Thank you. Okay, we have two more questions. What specifically causes kidneys to be a target in lupus?
That's an interesting question. And the short answer is it's an inflammatory process. So the autoimmune, the antibodies that are attacking the nuclear factors are doing so systemically and then cause inflammation, which harms the kidney. There are different kinds of kidney injury in lupus. And so some are more inflammatory, aggressive, proliferative, and some are related to the antibody that deposits in the kidney. So it depends, but the short answer is a result of the autoimmunity.
Perfect, thank you. And then I'm going to butcher this, but is there any preference in using losartan Cozar over Diavin?
No. No, so we don't think so.
Yeah.
We don't care which angiotensin receptor blocker your insurance covers.
Okay, and we have, two more just snuck in. Are the diet recommendations also applicable to those awaiting a transplant?
Yes.
Yes, okay.
Yes, the answer is yes. We think even after the transplant, diets should be followed. But as you know, I gave you a very simple diet, focusing on protein to reduce the progression. Some people have and low sodium, which I didn't highlight, to reduce blood pressure. But if you have problems with phosphorus, that has to be addressed before transplant. But after the transplant, you may have to increase your phosphorus intake. So those have to be carefully monitored and traditionally managed with dietitians.
Okay, and then we have, what is the impact on CKD from the newly approved weekly injection for obesity and diabetes?
Yes, so in diabetics, that injection of the GLP-1 has shown to have improved chronic kidney disease outcome in smaller studies And that's why the larger studies are being done. So we would say it would be a desirable treatment if it was recommended for obesity, if the person and diabetes to pursue. It probably hasn't been as profoundly effective as the SGLT2s, which may also cause weight loss, by the way. But it is a appropriate treatment modality.
Thank you. Okay, and then last question. What are your thoughts on kidney failure from oxalate nephropathy following bariatric surgery?
Oh, yes. So we've seen that. And in fact, I've seen it in non-bariatric surgery patients. And the answer is it's a difficult thing to do. You need to be important to nutrition in that situation can be critical. Right? You want to reduce oxalate. You want to carefully make sure you have adequate calcium intake. You want to be well hydrated, and you want to avoid other oxalate insults. For example, people love to take grams of vitamin C. We would recommend they not do that. But yes, it is a known complication. Yes.
Okay, perfect. Thank you so much. There is one more question. If you have, we're going to move on, but if you have a moment to maybe stick around and answer that last question in the Q&A, you should be able to view it, but we are going to move on. Thank you so much, Dr. Pahl, again, for being here. Great presentation.
And a shout out to our corporate mission partners for making this happen.